Okay, it's starting to snow outside, so I think I'm going to call it a day for today. Let's take a look. Today we were sent a case, and the notes mentioned that the dentist who sent the case is uncomfortable with this implant due to the defect on the palate and the need for the graft there. The particular question is, how do you plan this? How would you attempt to correct this if you were to do it? And then in his particular case, he wants to send it to his surgical specialist, but he wants to ensure that the implant's placed in a way that he can get a screw retained restoration. Let's start by getting this case planned because in looking at this, there's a couple of nice things that I would like to take a look at. So again, obviously with the CEREC data there, you already know that this is a digital workflow. You can see there's plenty of teeth here. The teeth were brought in. So let's take a look real quick at our virtual planning here of the virtual wax up. Unfortunately, we have a little bit of a tissue tag right here, or not a tissue tag. It's more of a artifact, probably a mirror or a finger or something, a retractor or something in the CEREC scan. So one of the things, again, one of my pet peeves. I have lots of pet peeves. It seems like these days. Is I like to plan our virtual restoration in the proper gingival architecture. So, my initial thought is more than likely that's actually designed pretty well. I mean, it's close, but I would have designed this just a hair higher. Okay, and the reason that is just again, it helps determine exactly where you want to put the implant vertically. And if we take a look at this, you can also see that virtual margin line, the way it's drawn now, gives us a little bit of a food trap area there. So that's why more than likely this would come out a little bit higher, as we can see with the recession on the adjacent teeth, come out a little bit higher and give us a little bit better emergence profile here. The good news is we could probably do a delivery technique which maximizes the tissue volume. But everything else looks pretty good. Again, in just being critical here, I always like to try to design these correctly. We can see that right here, you can see that the virtual wax up is a little bit higher right here. That cusp tip is a hair bit higher right there, and that lingual cusp is not as high as this. Now, I don't have the benefit of seeing the lower tooth data. Maybe the tooth is in crossbite or lingual everted or something. But again, I'd like to go ahead and get these designed to be in more ideal positioning. Just makes everything a little bit easier and better in terms of planning things out. So that said, let's move on to planning an implant. Site number 4. Typically we're going to do a 4 by 11.5 in this particular area. We're going to drop this implant in. We're going to put it where we think it goes, like so. Get our occlusal plane pretty level. Let me, as you can see, I was messing with this earlier. So now we want to go ahead and get this centered pretty well. Come to our axial view here, and now we can see our implant is pretty well centered here. Now the question is we got plenty of bone space here to do a 4.3 millimeter implant, and that would be mostly what people would end up doing here. Now what I want to do is point out why I don't believe that is our preferred implant in this particular spot. When I go to our checklist and we go down to our sleeve, what we'll see with this particular sleeve is that that sleeve does not fit. Now sometimes people will say to me, well, I could just adjust the adjacent teeth, and certainly that's an option, but what I see here is we'd have to adjust the adjacent teeth quite a bit to make that foot fit. God, my words are really bad today. So right there is our tooth, and this is how much of that ring goes in. Now, certainly you could freehand this implant, do a pilot drill, but what I have found is that the guide sleeve often is a very good indicator of the restorative room available for the proper size implant to go in there. So to me, this is an ideal case to actually place a 3.5 millimeter implant. Again, not because of the bone volume, but because of the restorative position. We can see that this tooth has tipped forward. Now, certainly if the patient were interested in properly correcting the space or maybe doing some restorative work on tooth number 3 to enhance that amount of space that we have, that would be a different story. But based on what we have here, now the other thing I would look at here is I would go ahead and just do a quick see, and we have about 6 millimeters of space. We need 1.5 millimeters on each side, so that leaves us about 3.5 millimeters for the implant restoratively. Now, again, because the roots are tipped and diverged, we have more than enough space there. So that was a good teaching point from this particular case. Number 2, now to me, the way I would ensure this, now again, grafting this for many people isn't that complicated or hard, but certainly when you deal with palatal tissue, it's a little bit more difficult. Getting primary closure becomes a little bit harder. It's a little bit more to manage. So this may be one that if you're more comfortable with your specialist, certainly we can understand that. So this would be one where I would probably make a guide for my surgeon. Maybe it's just a pilot drill guide, maybe it's a CEREC guide, something relatively inexpensive that can be used to at least help the surgeon place the implant. And I would send this information along with this plan right here that kind of outlines that, based on my planning, a 3.5 by 11 or 3.5 even by 13 millimeter implant is the more ideal position implant that you would like to use from a restorative space perspective to develop emergence profile and all of that. Now, this allows us, this plan right here, luckily allows us to do screw retained restoration. Let's say that the surgeon was not able to place this implant perfectly straight. The great news is if they're using a Nobel implant, Nobel has their angulated screw channel initially for the anterior and now for the posterior as well. I think they call it the FCZ. So now they can do up to a 20-degree angulated screw channel in the posterior to allow you to get screw access through the occlusal even on slightly off-angle place implants. So getting screw retained restoration in this particular case should not be that hard for any adept surgeon placing this on your behalf. So hopefully this makes sense, and I greatly appreciate sending this case in.